I mean, it is a simple case-based scenario. जहाँ पे we are trying to individualize the dietitian's role, or we are a nutritionist plan for a patient. So what I see is, there are so many types of diabetes, and many a times when I ask my MBBS or non-clinical colleagues, non-diabetology colleagues about how many types of diabetes are there, they tell type 1 type. But it is beyond type 1 and type 2. There are other specific types of diabetes. There's 1.5 diabetes. जिसमें you have maturity onset diabetes in young and late autoimmune diabetes of adults. Then you have maybe FCPD, fibrocalcific pancreatic diabetes. It is a specific entity, different entity. Then you have maybe gestational diabetes mellitus. Then endocrinology is causing diabetes, or other specific types. So in this, type 1 diabetes is presentation generally of type 1 diabetes would be a 17-year-old male or female who presents to you with a history of fever 5 days ago, 10 days ago, 2 days ago, and then uske baad se there's dryness of the mouth, a lot of urination, patient has become very, very weak, mother is really concerned, and there could be some infection, cold cough say it started, and now you check his sugar, GRDS is 590. There's no history of diabetes. There's no family history of diabetes. Coincidentally, this patient is having diabetes and she has presented to the emergency room. That is, the presentation is DKA, the type of diabetes is type 1. And in this insulin, you do the markers, GAD65 antibody, glutamic acid decarboxylase will be positive, C-peptide levels are going to be low, hardly less than 0.2. That's type 1 diabetes. And because there is no insulin reserve in the body, you have to manage this diabetes with insulin for life. After the recovery from DKA, there is a small honeymoon phase of diabetes for 6 months to maybe it could go up to 2 years. But and during that time, maybe a patient is not even requiring insulin, or the insulin requirement has greatly reduced. Patient is having episodes of hypoglycemia during that time. If you remember, 2019 lockdown के time पे there was one video that came from Baba Ramdev's ashram. A video जिसमें एक बच्चा with type 1 diabetes is telling बाबा के आश्रम में आने के बाद से insulin मेरा 60 units था 28 units हो गया, and it was propagated like a wildfire. Type 1 diabetes भी treat हो सकता है. That actually was the honeymoon phase of diabetes. Discharge के time पे the requirement was high. Patient was put on 60 units of insulin. And then gradually as that infection improved, his insulin requirement reduced significantly. It was 28 units. But that is going to increase again. Once the beta cell destruction is complete in those 6 months to 2 years, he will require more insulin as he grows. So that's about type 1 diabetes. Then you have the typical type 2 diabetes. Type 2 diabetes is where you have an adult male, higher side of BMI, 30 plus BMI, obese, 45 years, 50 years, 60 years, insulin resistance के signs है, sweating and all. His GR base is high. He says, Dr. Saab, 3 months ago, 6 months ago, I did my general body checkup. उसमें भी HbA1c was a little borderline, and up to it has crossed 8%. And my random sugar now is 273. Fasting sugar is also high. Posting sugar is also high. So these patients, they have a very good beta cell reserve. In fact, their beta cells are secreting more insulin to combat the insulin resistance that there is in the body. So this insulin resistance is making the body, for the same amount of glucose entry into the tissues, they are demanding for 2 times insulin, 5 times insulin. So your C-peptide level in that patient is going to be high. That is why they say managing type 2 diabetes with insulin is not the option, is not the treatment. For example, if you are considering कि type 2 diabetes को भी insulin pump लगा देंगे, he'll get continuous insulin. You can reduce the numbers by that, but will you be able to reduce the complications of diabetes in that patient due to obesity? I don't think so. Plus insulin and anabolic. Already insulin बहुत है, आप भी insulin और दे रहे हैं. Insulin resistance तो overcome हो जाएगी, लेकिन that is not the treatment. In that case, you will have to break the insulin resistance. Maybe drugs like pioglitazone, the first drug that was engineered for type 2 diabetes specifically. Drugs like metformin that are preventing that glucose output from the liver into the blood. Metformin you'll have to give. drugs like that. Once this disease progresses, this patient might come to you 18 years, 20 years, diabetes 45 se hai. Now I am 60-year old, sugar is still high. Yeah. For a good amount of time it was under control. अब now due to some reason COVID के बाद से sugar बढ़नी शुरू हो गई, and taken steroid sugar बढ़नी शुरू हो गई. They attributed to something that might not be relevant. But in those cases, you will have to take, at that time, beta cell exhaustion is going, and that is when he will require insulin, because now his C-peptide levels will come into the normal range. If it is in normal range in a type 2 diabetic, it means his beta cells are getting exhausted. That is an indication for you to start insulin in those patients. Similarly, type 1.5 may you have MODY, maturity onset diabetes in young. So he is a young male, 27-year-old, 25-year-old, 20-year-old, MNC में काम करने वाला बच्चा जिसका annual checkup हुआ. He is maybe asymptomatic and the degree of hyperglycemia in these patients is also very less. He comes to you with a HbA1c of 8%, 8.5%. And his fasting sugar is slightly elevated, 150 fasting, posting this 200 to 50. That is MODY. But in MODY, the most prominent thing that you will encounter is the patient telling that पूरे खानदान में diabetes है डॉक्टर साहब. My parents are diabetic. My grandmother was diabetic. My parents के siblings are diabetic. My siblings are diabetic, and almost all of us have developed diabetes at a younger age. That is why it is maturity onset diabetes in young. Maturity onset diabetes in young is autosomal dominant inheritance of diabetes, and that is why एक gene होना is enough for the patient to express diabetes. And therefore, the problem here is it is monogenic diabetes, and the problem here is the gate, the beta cell ka gate from which insulin is coming out, that is at fault. So they are very sensitive to sulfonylureas. There is production of insulin inside, but it is not coming out of the beta cell into the blood. So you give 0.5 mg of deviparite to that patient, or maybe 30 mg of glycoside, they respond very well. 1000 mg of metformin is also not going to produce effect in that patient, because he is not a diabetic because of insulin resistance. He is diabetic because of that gate ka problem. And that's about type 1.5 MODY. And then LADA is latent autoimmune diabetes in adults. This is that type of diabetes, type 1 diabetes. This person may be 30 years old, 35 years old. He comes to you. He is not very lean. He is not very obese. There are no signs of insulin resistance in this patient. This guy does not have a family history of diabetes also. No 3-generation family history. So you have ruled out type 2 diabetes, MODY bhi ruled out ho gaya. And he is not typical type 1 because he has never had, he gives you a history of 3 years of diabetes and I am taking these tablets. Those are that these medicines were working well. Now my sugar is high. So, and I have never been admitted to a hospital for a decade for diabetes. Type 1 is also ruled out. Most probably you are dealing with the case of LADA. You get a C-peptide done, it will be low, but it will not be as low as type 1 diabetes. 0.2 nahi rahega, it could be around 0.8, 1, like that. G8065 antibody is going to be positive in this patient because it is a hallmark of autoimmunity. And maybe this patient will also have other autoimmune conditions simultaneously, such as vitiligo or some thyroid issue. Thyroid, yes. Hashimoto's thyroiditis. So that's LADA, and these patients, they will eventually progress into type 1 diabetes and they will eventually require insulin. It could be 2-3 years, 5 years. It depends on the insult to the beta cell. Generally, viral fever होने के बाद, कोई भी infection होने के बाद, the beta cells are destroyed. The antibodies that are produced, they go and they hit the beta cells. Finally, we have fibrocalcific pancreatic diabetes, where FCPD is, are you able to imagine different personalities of different personas of patients when we talk about type 1 ऐसा रहता, type 2 ऐसा रहता, type 1.5 MODY is like this, type 1.5 LADA is like this FCPD, I think. FCPD is, this patient may be some laborer, generally malnourished people. This patient will give you a history of admission to a tertiary center in the past, maybe a couple of times, for pancreatitis. He may or may not be an ethanolic. After that, there was both exocrine and endocrine destruction of the pancreas. So these patients will have exocrine insufficiency also, for which we will have to manage them with maybe pancreatic enzyme supplementation. Plus, because there are no beta cells, there will be insulin deficiency, which will have to be given. Again, this patient will not give you a history of diabetic ketoacidosis. The main trigger for diabetic ketoacidosis is unopposed action of glucagon. Unopposed action of glucagon from alpha cells. In the FCPD, there is no alpha cell as well. Beta gaya. There is no alpha as well. So this patient will not have decay. Again, we will have to manage them with insulin, enzymes, etc. When we end gestational diabetes mellitus for the to prevent teratogenicity with due to any drugs, and to reduce the maternal and peripartum complications of the fetus, manage diabetes with insulin. Metformin is approved only in India, the Control General of India, but FDA has not approved metformin for in pregnancy. However, if we are prescribing metformin, we are safe from an Indian perspective, but we should prefer insulin wherever it is possible, even in gestational diabetes. And gestational diabetes ke cutoffs are also lower. Fasting diabetes target is 95 and post-insulin diabetes target is 120. Now, whatever the case, we say it is type 1 diabetes, or it is LADA, or it is FCPD, or it is type 2 diabetes who is in beta cell exhaustion now, a gestational diabetic mother. So all these people will be requiring insulin. When we are putting the patient on insulin, physiologically, insulin is secreted with every meal, even if it were a snack. And there is pulsatile secretion of insulin, basal insulin secretion, that takes care of the interprandial sugars and the fasting sugars. Now, when say it is type 1 diabetes, in all these cases, we will have to try to mimic that physiology. And in order to mimic that physiology, you'll have to maybe find out iska insulin sensitivity factor kya hai, ISF. So in type 1 diabetes, generally when we admit patients for DKA and the patient is exclusively on insulin, in 2 days, 3 days, we will get to know how sensitive this patient is. It is simply calculated by 1800 divided by the total daily dose of insulin. So ये patient का basal आप कितना दिए, say glargine कितना दिए, plus इसका prandial insulin कितना दिए. So 1800 divided by, say this patient is requiring 50 units of insulin throughout the week, then it is around 536. So this 36 means 1 unit of insulin in this patient can reduce sugars by 36 mg per deciliter. That is insulin sensitivity factor. So we have to give insulin to this patient. Say we started it randomly, weight based, some 0.3, 0.5 units per kg per day. And prandial insulin also, we kept 6 units 3 times a day. Here specifically, FCPD will require more prandial insulin when compared to others. Type 1 may also there is a requirement, but FCPD will require more prandial component. Arbitrarily you started 20 and 666. Or this patient has type 2 diabetes in beta cell exhaustion, but there is a beta cell reserve still to help you. And kuch aap usko oral medication also you are giving. The problem is, of one clinical scenario I'll tell you, you have started the patient on a previous insulin. The patient, as usual, every patient of ours, while leaving, they'll turn to you and say, Doctor Saab, khane mein kya khana hai? And you tell, go to the dietitian next door. Say he went to the dietitian. Now what the dietitian will tell is, diabetic patients should take small meals frequently. So she will nicely give a paper. She'll tell, these are the takes, these are some things that you should not take, and you should be taking 9 a.m. you should have your breakfast. You take dalchini ki chai, you do this, you do that, no sugar, no milk. She'll give nice chart, she'll give. 9 a.m. you take this, 11 a.m. you take this, 2 p.m. you take this. Your dinner should be at 7 p.m. Even if you feel hungry till bedtime, you do this, etc. Trust me, that is wrong. It will put all your efforts in vain. That is because this is your prandial component of premix insulin. Say, premix analog le raha, and 3 hours. This prandial component this prandial insulin ka effect is going to be index. However, basal component, this basal component is going to peak after some time. Say 6 hours ke baad it peak. And then you take 8 p.m. ko another dose of insulin, and patient is having dinner here, and after that also it is peaking somewhere here. 6 hours ke baad it peak. What I am trying to tell you is, for a patient who is taking premix insulin, his breakfast can be decent, his dinner can be decent, but his lunch should be small, and he has to take something at bedtime, some snack. So this is just 70 calories. Here also, probably a little more here, a little less. Otherwise, ye peak say his sugar will drop and he might have nocturnal hypoglycemia. So ideally this patient should have breakfast at 9 a.m., take his insulin 30 minutes before, then 9 plus 6, 2:30 p.m. he has his lunch without taking insulin, a short lunch, and dinner he has at 8:30 p.m. and by the time he goes to bed 3-4 hours ke baad mein, he has to take some, say, 2 biscuits or some milk, some snack like that. This is one regimen of premix when a patient is on premix twice a day or premix analog twice a day. However, when a patient is taking a co-formulation, where he is taking IDEC asp is a co-formulation, insulin degludec and insulin aspart, rhizodec is a co-formulation. So it is a rapid acting insulin. There is a basal component to it. Basal insulin. Basal insulin is peakless insulin. It is flat insulin. Say this patient takes one basal plus, that is IDEC asp, once a day. He takes it with the large meal. He says, Doctor Saab, when I am at home, say at dinner, I have a nice meal. But in breakfast and lunch, I hardly eat. While going to office, I am always in a hurry. And at work, I hardly get time to eat anything. I could snack le leta. So for that patient, say you gave this IDEC asp in dinner, either basal insulin only, you can give something, some alpha glucosidase inhibitor or a DPP4 inhibitor that can take care of these two needs. You know why I said this insulin sensitivity factor? When you give a cargos tablet to a patient, glucovay, you started some patient on glucovay for postprandial sugar. How much reduction does it bring in real world in postprandial sugars? I think it's hardly 40 mg per deciliter. So that is as good as 1 unit of insulin for that patient. But if this patient is requiring 4 units of insulin, I don't think we will be able to give 100 mg of acarbose to compensate for that meal. And acarbose is delaying the glucose absorption. It is not preventing the glucose absorption. Eventually down the intestine it is going to get absorbed. But it will get absorbed slowly. For those small meals, you can put something. Maybe a gliptin or an alpha glucoside to take care of this. And this big meal, let him have it at home. And at that time you are giving once daily co-formulation. If this patient says, I take 2 good meals and a small breakfast, you can give IDEC asp twice a day. It could be in breakfast and dinner or in lunch and dinner, anything, or breakfast and lunch. That is because of this peakless nature of the insulin. You cannot give premix insulin in lunch and dinner because यहाँ पे इसका effect will fade off say by 12 hours and इधर इसका effect will fade off at 12 hours. यहाँ पे there is nothing to take care of. Its effect is gone either. And somewhere here the patient will have hypoglycemia. If you're giving premix twice, which ideally should be, it has to be given in breakfast and dinner only. You don't have the convenience of giving it in lunch plus or minus breakfast or dinner. You cannot give like that. And however, co-formulation can be given because that co-formulation is peakless. And the prandial component of that insulin is taking care of both the meals. When he's having a small, just a sandwich and going to work, then this can be taken care of by your DPP4 inhibitors. Now when the patient is taking basal bolus, so there's one basal, he's taking say 30 units of some glargine insulin is taking, degludec insulin is taking, and he's taking prandial insulin 3 times. He can have it the way he wants. And that is what we mention in the insulin pump. When a patient is on insulin pump and is taking 3 times of basal insulin, bolus insulin, then he just has to mention how much carbohydrate he is taking. I understand it is difficult for many of us to calculate. In tools like ChatGPT, you just mention a picture of the plate. I'm having 1 bowl of rice, 2 chapatis, जिसमें तेल, oil नहीं है, and I'm taking this sabzi, this amount. It will give you a rough estimate of how much carbohydrate is there. You just have to input that carb in the insulin pump, and it will give you, accordingly, insulin will be delivered based on the insulin carbohydrate ratio, ICR, insulin carbohydrate ratio. How much insulin is required to take care of that much amount of carbohydrate. यहाँ पे it is very flexible. You can, the patient can take large meal and take large amount of insulin. He can take a small meal and take a small amount of insulin. That is ideal for type 1 patients. The challenge here will be to check in sugar levels 3 to 5 times daily, or maybe 6 to 7 times also. You checking pre-breakfast, post-breakfast, pre-lunch, post-lunch, pre-dinner, post-dinner, and bedtime. Bedtime insulin is to adjust your basal insulin ka dose, and these sugar levels are to take care of the perennial insulin dose. And if it is high, you give auto correction also. He's a 52-year-old diagnosed with type 2 diabetes 8 years ago. Type 2 diabetes 8 years ago. And his complaints are irresistible craving, hunger pangs, and he has gained 2 kgs in the last 6 months. He's feeling tired more often. He has gained 2 kgs in the last 6 months. Whenever a patient tells you he has gained weight, you have to see if the patient is on sulfonylureas. Sulfonylureas was weight gain, or maybe insulin also. If he's on sulfonylurea and he's having hunger pangs, it means he's going into hypoglycemia. It is time for us to reduce his dose rather than encourage his defensive snacking. Defensive snacking is never going to allow sugars to remain under control. Defensive snacking say patient will gain weight and insulin resistance increase hoga, and from hypoglycemia he will go into that hyperglycemia range. So this patient is hypertensive for the last 5 years. His dad had type 2 diabetes, diagnosed at the age of 42 years. Elder sibling history of diabetes, had a fatal MI at the age of 55. MI in a male at an age less than 55 is premature ASCVD, and MI in a female at an age less than 65 is premature ASCVD. So current RX is diabetes, diet, meal plan, physical activity up to 150 minutes per week, metformin 1500 mg in divided doses, dapagliflozin 10 milligrams once daily, amlodipine hydrochlorothiazide 5g by 12.5 mg of hydrochlorothiazide once a day, atorvastatin 20 mg once a day. So these are his medicines. So this guy is not even on sulfonylurea. He's taking metformin, dapagliflozin for diabetes, and it is 10 mg dapa, 1500 milligrams of metformin. Yet he's selling, he's having hypo and maybe gaining weight also. And yet he is doing physical activity of up to 150 minutes per week. Test to elevated blood sugar and lipid indices. Body weight is 62 kg, BMI is 24.8, and waist circumference is 102 centimeters. BP is 150 by 94. I think the waist circumference for a woman it is less than 100, and for a man it is less than 90. BP is 150 by 94. HbA1c 8.1%, fasting blood glucose 179, total cholesterol 231, triglycerides 325, LDL cholesterol is 151. So this is your typical ADD, atherogenic diabetic dyslipidemia picture in diabetes, and HbA1c is not a target, FPG is 179. I think because of the defensive snacking, his sugar is not under control. I don't have the time to regularly exercise. I feel tired. I'm trying hard to follow the diet recommended, but I feel hungry and cheat frequently. Are you following the lifestyle changes we discussed in the last visit? So he says, I'm quite busy. I don't have time for that. So clinically, clinical impression is he is a poorly controlled, non-standing type 2 diabetes. He is diabetic for the last 8 years, high atherosclerotic cardiovascular disease risk, and he is non-compliant with recommended MNT, medical nutrition therapy, and he has a poor physical activity routine. In a patient like him, how to proceed with nutritional management? This guy, he says, time nahi hai for exercise. I'm not able to have food, the diet recommended by the dietitian, because I'm feeling hungry and I'm cheating. I'm feeling weak. I'm feeling hungry. I'm having hunger pangs. In this patient, what do you think we should do? Doctor says he is non-compliant. Targets and all is taken. So yeah, maybe we can give him a medical nutrition therapy with DSM formula and do a counseling and both. So diabetes specific nutrition DSN formulae are specialized forms of MNT. Medical nutrition therapy is an integral component of management of diabetes by providing personalized dietary guidance and counseling. DSN formulae consist of macro and micronutrients to manage dysglycemia, malnutrition, and other cardiometabolic risk factors. DSN formulae contain modified carbohydrate, high protein, high UFA, high fiber, vitamins and minerals. Fiber because it gives you a feeling of stomach fullness. Here it is offering you the essential energy. Macro and micronutrients also you get it. These formulae have low glycemic indices. So in a patient like him, why should we use DSM formula along with standard of care? Guidelines recommend diabetes specific MNT as a part of first line intervention. You look at any guideline, RSSDI guideline, ADA guideline, IDF guideline, all of them at first it will be lifestyle modification. where it is medical nutrition therapy plus the physical activity plus OAD has to be started. It is not you try this and then come after 3 months. Both of them have to happen together. We feel, or maybe the evidence is telling, that people are non-compliant with lifestyle modification. And even if they are compliant, it is not long-term, it is not sustained. That intervention is not sustained. Guidelines recommend diabetes-specific MNT as a part of first-line intervention, and clinically proven to manage blood sugars helps weight management also. Because of the snacks, he is gaining weight, already a type 2 diabetic. So we are telling, if we are giving him calories, giving him something that is filling his stomach, yet not increasing his weight, there are no much calories compared to what he is taking otherwise, then that is going to help. So ADA 2025 Standards of Care in Diabetes recommends diabetes specific MNT to achieve treatment goals. An individualized MNT program as needed to achieve treatment goals is recommended for all people with type 1 or type 2 diabetes, pre-diabetes and gestational diabetes mellitus. Healthcare professionals should refer people with diabetes for individualized diabetes specific MNT at diagnosis and as needed throughout the lifespan. MNT is an integral component. Any patient who gets diagnosed with diabetes, he might not ask you, his spouse will ask you, his wife will ask you, Doctor Saab, खाने में क्या करना है? What is it that they have to stop for this patient? Generally, for diabetic patients, we tell patients, you can have rice once a day. Otherwise, we try to have roti. That is what we tell. And if your nutritionist doesn't know how this premix insulin is working in the background, then more often than not, she will tell, lunch mein rice le lo. And that will cause dysglycemia. Okay, she should have told him to have it either in breakfast or dinner, because that is the time the patient is taking insulin. So MNT is an integral component of diabetes self-management and must be continued even after pharmacotherapy is initiated. So MNT with diabetes-specific nutrition formula, it helps improve glycemic control and manage weight without increasing anti-diabetic medicines. So HbA1c, a reduction of around 1.1%. In fact, a good lifestyle modification, diet and exercise, in the first year of diagnosis can reduce HbA1c by 2%, up to 2%. It is very powerful. And 2% is something, metformin या glimepiride से जो benefit मिलता, that is 2%. It can improve your time in range, and postprandial GLP-1 secretion also is enhanced by 280%. 280% is what gliptins do. Gliptins increase your GLP by 2 to 3 times. That is 200 to 300%. But GLP-1 RAs, GLP-1 receptor agonists, they increase it by 50 times, 20 times, 25 times. You look at Mounjaro, semaglutide, Ozempic, Wegovy. Metabolic health, so there is weight reduction, there is improvement in the lipid profile, and there is improvement in BP. When there is improvement in the insulin resistance, sugars are better, your triglycerides and ADD automatically settles. So there is weight reduction of 8 to 12%, triglycerides by 22%, total cholesterol by 5%, HDL by 7%, and there is a improvement in systolic blood pressure also by 7%. So common myths about DSL formula with facts. So it only reduces hunger, fatigue, etc. And does it actually reduce blood sugar? Is it only used in patients to improve nutritional status? I don't think we actively prescribe nutritional therapy to patients. Do we prescribe any protein powder which is diabetes specific to patients? Maybe when a patient asks for it. But this can be recommended when you want to give feeling of stomach fullness to the patient, yet not increase his blood sugars. For example, in premix insulin, lunch mein this can be fit, or at bedtime this can be fit, or when a patient says lunch and dinner ke beech mein I feel hungry, then this can be put. So it is a specialized MNT, guideline recommended as a part of standard of care. SOC standard of care is clinically proven to reduce HbA1c and glycemic variability. Glycemic variability is your time above range, below range and in range. DSN formula supports weight management and reduces cardiometabolic risk. By improving glycemic control, DSN formula helps improve diabetes symptoms. This patient is on metformin and dapagliflozin. They are anti-hyperglycemic drugs. They are not hypoglycemics. Yet he is having hunger pangs. So in this patient, you can recommend this. He will have that feeling of stomach fullness, but at the same time will not take extra calories. How do you manage hypoglycemia? Any volunteer? How do you manage hypoglycemia? If a patient says sugar dangerously low हो गई थी, तो क्या करना चाहिए? Say patient is conscious.
He took to take some stuff at the time.
Okay.
He was really available.
Right. Anything else?
Glucon.
Glucon-D. Yeah.
Or glucon.
So, conversation about hypoglycemia should happen with the patient at the time of diagnosis, or at least when we are prescribing insulin, or when we are putting the patient on drugs that can cause hypoglycemia, such as sulfonylureas. I learned with time about this. Otherwise, we would only talk about hypoglycemia when patient reports hypoglycemia. The best way is, if your patient is conscious, give him 3 spoons of Glucon-D in a glass of water. Ask him to repeat his sugar after 15 minutes. If it is still less than 70, repeat Glucon-D. Then check after 15 minutes. In fact, the other day, a few days ago, we had a patient in the OPD. She went for vital check before coming to me. That is how we do. Usme, her sugar was 49. My nurse panicked and came to me. Sir, her sugar is low. Do you want me to put D25? I said, no, you give Glucon-D. She gave 15 minutes ke baad, we instructed to check again. She checked 54 tha. Just 54. 5 mg rice. And then I said, okay, no issues. She's conscious now? Yeah, she's conscious. Give Glucon-D again. She took Glucon-D again. Again after 15 minutes, it was 75. So what I'm trying to tell is, even normal people, you and I, can have sugar in the range of 58 to 60 at times when we have skipped our meal. That is normal. We don't have to worry. Our liver is normal. It is going to take care. Our sympathetic autonomic nervous system is normal. They are going to take care. But in a diabetic patient, they are usually disturbed. So in those patients, it might be difficult. But if they are conscious, we don't have to worry. Now, for a moment, please think about this. Had I given D25 to that patient, or my duty doctor had given D25 to that patient, her sugar would have increased significantly. From hypo, she would have gone into hyperglycemia. Number one. Second is, imagine her state of mind after going back home. What would she think? She would think, वो तो अच्छा हुआ मैं हॉस्पिटल में थी, ये तो मेरा क्या हो जाता. This is what she's going to think. And unfortunately, neuroglycopenia जब होता, very low glucose levels पे, you and I as doctors are afraid of that. And how we try to extrapolate it even to a conscious hypoglycemic patient. That is only for unconscious hypoglycemic patients. जिसमें we tell glucagon का injection रखो घर पे देना, else you bring to the hospital. Hospital आने के बाद तो देखिए dextrose, P-MODY. It's our endeavor, would be our endeavor to remove that fear of hypoglycemia from our patients. Conversation में, at the time of diagnosis, or when we are prescribing the sulfonylurea, or when we are putting the patient on an insulin, let us tell them अपनी तरफ से, you can have hypoglycemia at times. If you develop such a thing, these are the symptoms of hypoglycemia. You first need to check your sugars. If it is less than 70, please take this Glucon-D. Automatically the patient will ask you, so you want me to keep a Glucon-D at home? Yes, please keep Glucon-D with you. Sorry for the erratic from the topic, but yeah. Now, in a patient like him, how does DSN formula aid in managing blood sugar levels? So DSN reduces HbA1c 8.1 है, and we said DSN से, proper DSN से 1.1% HbA1c reduction is possible. DSN formula reduces glycemic variability also. If you want more data, here it is. DSN formula helps reduce HbA1c and glycemic variabilities. 1.1 reduction in HbA1c from baseline within 6 months of DSN formula and lifestyle changes. Significantly greater improvements in MAGE, around 28.8 Hg per deciliter. And it is a part of standard of care. It reduces HbA1c and glycemic response in Indian adults with type 2 diabetes. Significantly greater reduction of HbA1c by 0.9% and reduction in the average value of 4.8 versus 1.1 at control. MAGE is your mean amplitude of glycemic excursions. How much is that glycemic excursion? Uska amplitude. Transcultural diabetes nutrition therapy algorithm, the Asian Indian application. Asian Indian DNA. Increase awareness of the benefits of nutritional interventions. Encourage healthy eating practices accommodating regional differences. Enhance the implementation of existing clinical guidelines and simplify nutrition therapy. We have to simplify. However qualified your nutritionist might be, we don't have to rely completely on them. We should not rely completely on them. We have to learn the basics of medical nutrition therapy in diabetes. And in fact, even when we hire them, these days, pharma companies, they support clinics by putting nutritionists, diabetes educators working in your clinics also, maybe once a week or daily for some duration, 3 to 4 hours ke liye. But don't think that they are trained completely and they are going to take care of this on your behalf. You will have to discuss these things with them. And DSM formula significantly reduces glycemic variability in HbA1c. Indian PDNA study, the pre-study AGP profile, ambulatory glucose monitoring profile, and you look at this variability, how it has reduced. Wider this wave, more is the variability across 14 days. Narrower the wave, less is the glycemic variability. So this is the green zone, the time in range wala. Here it is time above range, and here it is time below range. This line is time above range. This is time in range, this is time below range, and this is called ambulatory glucose profiling. Here, after giving in these 47 subjects, when they looked at the daily patterns, this excursion was gone, and here it is. So reduction of an area under the curve of AGP was seen overall. This is area under the curve. This is the curve, area under the curve. So lower the area under the curve, less is the glycemic variability. Of AGP was seen overall at the end of 1 year. AUC reduced by 64% and HbA1c by 1.2% at the end of 1 year. Treatment target goals for this patient. HbA1c I would want less than 7% for this patient. BP 120 by 80. 130 by 80 is the target. Less than 130 by 80 is the target. For general population it is 140 by 92. Fasting plasma glucose, 80 to 130 I'm fine. Total cholesterol of less than 200 and LDL of less than 100, ideally less than 70. So I would recommend DSM formula as part of standard of care. Difference between DSM formula and standard formula. DSM formula has different composition designed to improve blood glucose levels. Not aware about the differences, consider them the same, would like more data. Let's have no data. Ideal attributes for evidence-based diabetes specific nutrition formula prototype. So you need a composition and its usage and clinical evidence. Slow release carbohydrate blend with high dietary fiber per serve. Takes care of the constipation, takes care of amplitude of excursion. High quantity of protein per serve. How much is the protein? Size of your palm. Fat blend for heart health, high in NUFA per serve. All vital micronutrients for nutritional adequacy and lactose and gluten free. If your patient is intolerant to it, there's no point in giving the world's best formula to your patient. It should have a low GI and it should be suitable for tube feeding also. If your patient is acquitted, mild tube and all. Special population is pregnancy and lactation. Clinically proven with positive outcome on glycemic control and weight management. Robust national and international clinical studies. Admitted patient on rice tube feeding. How do we manage his insulin? इसको continuous feed दे दो. Gravity से it is flowing 24 hours. For that time, give a basal insulin. You don't need a prandial insulin for that. Your basal will take care. You tell your dietitian to make 300 calories. Okay, 3 food glasses, whatever. उसके बीच में some 50 calories in between. This should be the main meal, mimicking your breakfast, lunch and dinner. And here they can be small meals, around small feeds of 50 calories like that. And this you can treat like basal bolus. So one basal to take care of this, and 3 boluses to take care of this. And if postprandial is high, give auto correction here and manage it. Okay, I really want to tell this again. If you are trying to manage diabetes of hospitalized patients with the sliding scale, it is never going to be fruitful. It is never going to be full. Many a times you and I and our duty doctors, they blindly follow the scale. 400 है 20 दे दो, 100 है इतना दे दो, मत दो, 200 है 4 दे दो. If you are doing that, you will never be able to discharge patient by controlling sugars. So उसके लिए always you have to have this approach only. Say 6 units of bolus, say 20 units of basal, and then do the auto corrections, manage sugars, and then discharge maybe similar regimen to the patient. He might not be able to do 6-point SMPG, but if you premix में या formulation में करके you can send the patient. Yeah, so clinically it should be proven, but they have a lot of controlled trials with positive outcome on glycemic control and weight management and robust national and international clinical studies. Yeah. So in a patient like him, how does DSM formula function in the body as an effective medical nutrition therapy? It manages blood glucose level and it promotes satiety. It manages muscle health and it balances gut health. Coming to muscle health, I want to tell one thing here. Whenever we talk about obesity management, and there's a lot of noise about incretins these days, GLP-1 receptor agonist, GLP plus GIP, your triple cretins are coming now, retatrutide, there's CagriSema in the pipeline. So all these drugs, when they lose weight, they are also going to affect your muscle. And this is one concern that they are raising. people are raising, doctors are raising about, this is causing muscle loss also. No, it is causing sarcopenia. It is not specific to incretin therapy. It is for any way of whatever modality of weight loss you choose, you are also going to lose a muscle as a part of it. Weight loss may, that is why exercise is recommended so that the muscle is retained. Gym karne se you are not going to lose weight. Cardio karne se you are not going to lose weight. It is only to retain your muscle while the diet takes care of the excess fat. So yeah, in these patients also, when we're giving anything, so we need to clarify to the patient that this is something that is not specific to incretin therapy. It is common to any weight loss modality. DSN is also taking care of your muscle health and it balances the gut health. It helps maintain nutritional adequacy and maybe it takes care of all the above. So DSN formula is shown to enhance the insulin release and promote GLP-1 secretion. This is similar to what your alpha glucosidase inhibitors are doing, especially acarbose. The undigested carbohydrate goes into the large intestine. It causes secretion of GLP in the intestine from the enterocytes. So slowly digested carbohydrate plus MUFA, PUFA and high quality of protein, high fiber, vital nutrients namely minerals and vitamins. So all of these, fructooligosaccharides, FOS, increases GLP-1 levels, increases insulin release and manages blood sugar level, promotes satiety. It manages muscle and gut health and it helps maintain nutritional adequacy also because of the minerals and all that it is having. And why is it that we are able to use GLP-1 for weight loss? It is causing insulin release, but the first phase of secretion of insulin will not be because of GLP-1. If it has already started to come, then it can pitch it and cause more insulin, but it itself cannot cause hypoglycemia. Takes care of the muscle and gut health and maintain nutrition adequacy. So for a patient like him to get to goal, how can one initiate DSF formula as a part of standard of care in diabetes management? So partial meal replacement, healthy snack, complete meal replacement, any of the above. It can be any of the above. It depends on how much quantity of the diabetes specific nutrition you are giving to the patient. So it can be a partial meal replacement, it can be a snack or a complete meal. You don't take lunch, take only this. Or you had your lunch and dinner, each way you are feeling hungry, you take this much amount of this. So approach to recommending DSL formula in patients with diabetes as outlined in the Trans-Cultural Diabetes Nutrition Algorithm, TDNA. For obese or overweight patients, BMI more than 23, 2 to 3 DSN formula servings as part of a reduced calorie meal plan. So you just morning and afternoon you replace it. You tell them to take this and maybe evening and noon he can have something else. For normal patients where BMI is 18.5 to 22.5, 1 to 2 DSN formula servings per day to be incorporated into a meal plan. For underweight patients, 1 to 3 DSN formula servings per day based on the clinical judgment. For a patient like him to get to goal, what should be the duration of DSN formula use in this patient? 3 months until follow-up review, to be continued for more than 6 months based on follow-up evaluation. 6 months until follow-up review must be continued even after pharmacotherapy is escalated or revised. So it is kind of indefinite. Duration of DSN formula use and impact of glycemic control across studies. So Mohan and others, Dr. V. Mohan, Chennai, they did this study 3 months, significant decrease of HbA1c of 0.9%, and others 6 months, significant decrease of HbA1c by 1.1%. Joshi and others 1 year 1.2% reduction in HbA1c. I think Joshi is Shashank Joshi from Mumbai. He's a very big pathologist, just like Dr. V. Mohan. 2 servings of DSN formula as meal replacements, breakfast and evening snack a day, and calorie restriction and individualized meal plan with 7 simple menu, preferably by a registered dietitian. Individual choice of physical activity for at least 150 minutes per week. Many times I see this in prescriptions that come from corporate hospitals. They write 1400 calorie diet, 1600 calorie diet and send the patient to the nutritionist. How is that calculated, that number calculated? That is calculated based on ideal body weight. Ideal body weight is a BMI of 21 for men and a BMI of 23 for women into their height in meters square. You take say 121 into this patient is 1.8 meters. 1.8 into 1.8, whatever the number. That is his ideal body weight. Say this is 2 2s are 4 21 into 4, approximately I'm very sure. So it is 80 kgs. That is his ideal body weight. So based on the ideal body weight, we have to see his calorie requirement for the day. So say 80 into, you have to see now, is he a sedentary worker, moderate worker or a heavy worker? If he is a moderate worker, say 80 into 35. A sedentary worker 80 into 30. Heavy worker 80 into 50. He is a laborer 40. Many of us it is 35 or maybe 30. But for a hospitalized patient, for somebody who is bedridden, it is 30. So in urban it is 35. So 80 into 35 would be 2800 kilocalories. So this 2800 kilocalorie is that number, that energy that this patient needs so that his daily requirement is taken care of. Now if you want to reduce his weight, that has to be, if you're say type 2 diabetic patient, he's obese, you tell him, man, you have to reduce at least 500 kilocalorie per day. So it is 2300 calorie. And the doctor writes 2300 calorie diet to this patient. And in Full Life Nutrition, what they do is, they give a VLED, very low energy diet, very low. It has all the nutrients, but it is very low on energy. If the patient is requiring 2800 calories, they'll give 800 calories. So in 6 months, the patient will reduce weight by 18 kgs, 20 kgs. And if he doesn't continue the VLED, then the patient will have rebound weight gain. When we are trying to treat obesity, why are gallbladder problems more common when we treat obesity after losing weight? Why is it that gallbladder stones problems they are common? In fact, post-operative bariatric surgery के बाद also some people have gallstones. That is because the gallbladder is remaining in a fasting state for long. Its contents are not coming out. Hana gaya to cholecystokinin आएगा. That is going to pour the contents, pour bile into the intestine. If it is remaining there only, then stones can precipitate. So gallstones are common. So to avoid gallstones, what they say is, with each meal, whatever they are taking, especially in BLED diets, or at least one meal per day, they should take 1 teaspoon of oil. Oil gets in, contents will come out, and stones will not precipitate. So 2 servings. This patient, atorvastatin dose was increased from 20 mg to 40 mg because he has a risk of premature atherosclerotic cardiovascular disease and individual choice of physical activity for at least 150 minutes per week, and calorie restriction and an individualized meal plan with 7 simple menu, preferably by a registered dietitian. To continue other medicines with no change, metformin 500 TID, amlodipine and hydrochlorothiazide, you continue dapagliflozin 10 mg once daily, to follow up after 3 months with blood sugar reports. Your patient is on 500 mg TID of metformin. He comes to you, he's not taking any other sugar tablet. He comes to you with a fasting blood sugar of 67. What do you do to the metformin dose? He's type 2 diabetic. Type 2 diabetic on metformin 500 TID. Fasting sugar is 67. What do you do to metformin dose? So, metformin cannot cause hypoglycemia. That is normal for the patient. So, you either need not change, or guidelines tell put the patient on the maximum tolerated dose of metformin. You can even go ahead and increase the dose. You don't have to worry. Unless the patient is on concurrent sulfonylurea, then you have to be careful. You have to reduce the dose of sulfonylurea. Okay, so now in this patient like him, to improve compliance, give specific instruction on taking DSM formula. If you are giving non-specific instructions, they will never be followed. When we are not specific about something, patient is himself asking, डॉक्टर साहब शुगर लो हो गई तो क्या करना? एंड यू टेल कुछ चॉकलेट खा लो, कुछ मीठा खा लो. You say कुछ मीठा खा लो, he's going to open the refrigerator and eat all the gulab jamun that are there in the fridge. Therefore, we have to give specific instruction and adopt motivational strategies, encourage a discussion, evaluate compliance and regular follow-up visits. Layering, some patients are manipulative. I think all of us are manipulative. They tell you, Dr. Saab, aap bole baat se every day I'm doing this, that, he'll take 2 minutes extra of your consultation time just to show how disciplined and sincere a patient he is of yours. But you go to a wedding where he invited you, you will see his plate full. For a patient advice, the DSN, general instructions to improve compliance with DSN formula is how to take it, how to prepare, how many scoops, how many times a day, how long to continue taking it. These questions should be answered for that patient. कब लेना है, कैसे बनाना है, कितना डालना है, कितने बार लेना है, कब तक लेना है. and at 3 months follow-up. You are doing extremely good. Let's continue with the same prescribed medication and DSM formula. Yes, sure, I believe it is helping me. Patient will himself care. At 6 months follow-up, compliant with prescribed DSM formula, decrease in body weight, reduction in HbA1c, improvement in lipid profile, no increase in number of medicines, patient confident to self-manage. HbA1c before initiating was 8.1, at the end of 3 months it was 7.6, at 6 months it was 6.9, body weight 62, 60, 57, BMI 23, BP 137 by 88, total cholesterol 256, LDL cholesterol 135, triglycerides 320. Your progress looks great. Keep up the good work with the meal plans and DSM formula. Thank you, doctor. So what other patient profiles can benefit from DSM formula as part of standard of care? Newly diagnosed type 2 diabetes, pre-diabetes, type 2 diabetes associated with obesity or overweight, long-standing type 2 diabetes with comorbidities, gestational diabetes, type 2 diabetes patient recovering from acute illness or post-hospitalization, elderly type 2 diabetes, pre-diabetes, type 2 diabetes with treatment-induced muscle loss. So all of these patients can benefit with diabetes-specific nutrition therapy. So the take-home message is diabetes-specific nutrition formula as a part of medical nutrition therapy is considered an integral component of management of diabetes. DSM formulae contain modified carbohydrate, high protein, high UFA, high fiber, vitamins and minerals compared to standard formulae. ADA recommends individualized diabetes-specific MNT diagnosis and as needed throughout the lifespan. DSM formula is proven to improve blood sugar level, HbA1c, glycemic variability, cardiometabolic risk factors, and weight without increasing anti-diabetes medicines. 1 to 2 DSM formula servings per day optimized to the clinical findings. HbA1c, BMI, and patient preference is recommended. Life to the blessed Abbott Glycemic Guardians Conclave. Thank you very much for participating.